Bhaskar, please, you can start.
Yes, sir. Good morning, everybody. This is Dr. Bhaskar, Secretary, ISA Tamil Nadu. We are entering the second program, online CME program. Today's topic theme is the obstetric anesthesia. They have got the Professor Emeritus, Dr. Kanan sir from Tirunelveli, and other person is Dr. Mangalswati. Before starting of the meeting, I would like to two of our senior members, anesthesia, passed away last week. So let us maintain 1 minute silence in the remembrance. Number one is Dr. Lalit Mahardita, who has been the chief editor of IJA, and Dr. Subramanian Bhardiya, he was the chief anesthesiologist in Stanley Medical College, and was working at Karpanayaga Medical College as HOD. Both of them passed away last week. So I request everybody to maintain 1 minute silence in their remembrance. Sir, shall we continue the meeting, sir?
Yeah, please.
Yes, so now I hand over mic to our President, sir, Dr. Kumar.
Respected national office bearers, ISA state, JC members, past presidents of ISA Tamil Nadu, Dr. Muthukrishnan sir, immediate past secretary Dr. Kirubagaran sir, our ISA state team, academic chairman Dr. Sudarshan sir, vice president Dr. Ramudarani madam, secretary Dr. Bhaskar, treasurer Dr. Giridharan, and today's moderators Dr. Veereshan sir and Dr. Periyasamy sir, speakers Professor Dr. Kannan sir, Dr. Mangalswati, all the branch president, secretary, treasurers of ISA Tamil Nadu, members of ISA Tamil Nadu, my dear postgraduates. A very good morning to everyone. On behalf of ISA Tamil Nadu, we welcome you all for this ISA state academic meeting. This is the second meeting, as our secretary Dr. Bhaskar has already mentioned. So it will go on every month with all your support and active participation. As we communicated and requested on behalf of ISA Tamil Nadu, the academic meeting from members of ISA Tamil Nadu should not overlap, and there should not be any parallel meeting within the members of ISA Tamil Nadu. And it is well adhered today by your members. And thanks to everyone for all your cooperation and support for adhering this, not overlapping any of our ISA meetings within the members of ISA Tamil Nadu. As we lost our two of our senior members, Dr. Lalit and Dr. Subramanian Bhardiya, due to unexplained sudden cardiac arrest, we request everyone to take care of your health. Though you are very busy in your professional work, please take care of your health. This should not happen in future. So please take care of your health. That is everyone's priority. And our ISA Tamil Nadu state conference will be conducted in July 2022. So the venue inspection by the state office bearers, state EC members, is planned on 27th February, coming Sunday at Madurai. So request all the EC members to attend the venue inspection at Madurai in 27th February, Sunday. So with this, I once again welcome you all for this academic meeting. Have a great day. Thank you very much. Long live ISA. Thank you. Over to Bhaskar, please.
So now I hand over the mic to our academic chairman, Dr. Sudarshan sir, to take over and conduct the CME, sir.
Good morning, everyone. Respected President, Secretary, Vice President, Treasurer, all the past office bearers, past presidents, and senior members of ISA Tamil Nadu. It's a great pleasure presenting you the second academic program, ongoing academic program monthly event of ISA Tamil Nadu. This time, it was chosen to be one of the most interesting practical subspecialty of anesthesia, namely the obstetric anesthesia. To present it to you, we have two very eminent chairpersons who to moderate the session, and we have two really well-known speakers to present the chosen topic. I have the great pleasure in introducing you the two chairpersons. The one is my past president of ISA Tamil Nadu and my good friend, Dr. Perisami Sakya. And of course, the second chairperson is Dr. Veeresham, Professor Veeresham from Andhra Pradesh. Dr. Perisami Sakya is currently the senior assistant professor in Government Medical College in Trichy, and also he runs the hospital as a managing director of Arogya Hospital in Trichy. He is well known amongst the ISA circle and also all the members of anesthesia fraternity for having been very, very active ISA president. And I had the great pleasure of working along with him as a secretary of ISA Tamil Nadu. That was in the year 2017. And he had taken a lot of responsibility in ISA activities. To mention a few, he was Trichy, to start with, a member of ISA Trichy for several years, and became the president of ISA Trichy in the year 2010, and continued for a period of 2 years, and during which time he initiated a lot of good activities, including revision of anesthesia fee structure at Trichy, that is still holding well, and a lot of people remember him for that good activity. And he had been the organizing chairman for the Trichy State Conference held in 2013. And as I told you, he was a state president of ISA Tamil Nadu in 2017. And during which time he implemented a lot of important activities, such as presenting the basic duties and responsibilities of the anesthesia protocol of the ISA Tamil Nadu, and the standard anesthesia consent form, which was designed and presented, and so many other activities of getting ISA members together. And also, as a state president during that period, he was a South Zone chairman, which was South Zone Conference organized in Trichy in SRM Medical College, which we all remember very fondly as one of the major conferences in the last decade. And he had been invited faculty for many conferences. I'm very happy to pleasure and inviting you, my dear friend and good colleague, Dr. Professor Perisami sir. The second chairperson is Professor Veeresham. He has a dual advantage for being as an anesthesiologist and as a surgeon. He is an anesthesiologist as a professor of anesthesiology, and also an ENT, head and neck surgeon. He is qualified diploma in ENT, otorhinolaryngology, and he is a president of Indian Society of Anesthesiology, Telangana state currently. And he is also the president of Osmania Medical College Alumni Association, and also Telangana Medical and Dental Teachers Pensioners Association. Several responsibilities he has held in the Indian Medical Association of Hyderabad City Branch. And he is very well known to all the people who interacted with him during many conferences held in Andhra Pradesh, and he is also a very nice friend of mine, and introduced by a lot of stalwarts and backed up by many people in ISA Telangana. And I'm very glad to invite you as a chairperson for this session. So over to the chairpersons now to introduce the speakers and carry on with the academic deliberations. Thank you, Dr. Veeresham and Perisami Sakya. Over to you. The first speaker will be Professor Kannan, who will be introduced by Dr. Veerasham, and the second speaker will be introduced by Dr. Periyasamy. Thank you.
Good morning. Can I go ahead?
Yes, sir.
Yeah. Good morning. Thank you for the invitation as a chairperson, moderator for the webinar, second webinar in Tamil Nadu. Very good morning and happy Sunday. So after this, and I thank you the President, Mr. Kumar, Dr. Kumar, and the Secretary, ISA Tamil Nadu, Dr. Bhaskar, and the Treasurer Giridharan, and the academic renowned person, chairperson, Dr. Sudarshan Kasturi. I have been the friend of all of them, and my responsibility to introduce Dr. Kannan, Professor of Anesthesia, MD, and he is the Professor Emeritus in Tamil Nadu, and he is also consultant for MGR Medical University in 2021, and he is a former National Governing Council member of Indian Society of Anesthesiologists. He has also worked as a editorial board member of Indian Journal of Anesthesia 2008 till date, and he is the former president of ISA Tamil Nadu from 2008 to 2010 as a very good president in his tenure. And he is having his public academic publications, original articles about 4 in number. He has given so many lectures and free paper presentations in Indian Society of Anesthesiologists conferences and CMEs, roughly about 50 to 70. And he is a recipient of Best Postgraduate Teacher by Indian Society of Anesthesiologists Tamil Nadu in 2011. He is a best teacher also awarded by the MGR Medical University. For his credit, he is the recipient of Lifetime Achievement Award.
Veerasham sir, it is network issues. Nothing is audible.
So in that case,
Sudarshan sir, you
Sir
please.
Sudarshan can take over and
Professor Kannan is
yes, sir.
Yeah, Professor Kannan is a very well-known personality amongst us. Amongst all the accolades, I would say he's a very, very humble, very friendly. Professionally, he is par excellence. There is nothing much we can all tell about the Professor Emeritus. We are all very far too juniors to tell. But as a person, we have had a lot of close interactions and such a father figure, guiding personality for ISA Tamil Nadu. And he has been a steering force for ISA Tirunelveli in all its activities and projected Tirunelveli ISA at the national level and also ISA Tamil Nadu at the national level. And we are most proud and very happy to invite you for, that is one of his favorite topic, obstetric anesthesia. He has been one of the reference personalities in the South for any queries in obstetric anesthesia. I'm quite sure you will all be enlightened with his speech. And may I request Professor Kannan to present this topic. Very, very interesting topic. I think you all will really enjoy the presentation of Professor Kannan. And we all get the dilemma how to manage these scenarios of high-risk obstetric anesthesia amongst this thing, patient coming in with heart disease. Many a times, every one of us will be presented with one such case in our practice every now and then patients with heart disease coming in for an obstetric anesthesia. His topic, his presentation style is so unique, very practical. Now, he doesn't want to share any theoretical numbers and things, which is too confusing, but very practical personality. May I have a great pleasure in inviting Professor Kannan sir to share his thoughts on obstetric anesthesia and heart disease, practical considerations. Thank you, sir.
you, Sudarshan, for a colorful introduction about me. And then I
It's
thank
all true, sir.
I thank ISA Tamil Nadu for inviting me for this academic lecture. I thank Dr. President, Dr. Kumar, Vice President, Dr. Amadharani, Oscar, the past presidents here, like Dr. Muthakrishnan, Swami, and I thank all the members for inviting me. And I wish you a good, great morning today. Let me share the slides. One minute. Today is, as Sudarshan said, it is an interesting and practical. Am I audible?
Yes, sir. Very well, sir. Very well. Please.
It is a practical scenario. Every day and day out, we meet it. Most of the anesthetists, exception, maybe an exceptional features like Kumar and others may be dealing only with cardiothoracic, but most of the anesthetists will be in an obstetric practice is the bread and butter and day-to-day activity of them. And with this introduction, I go into the subject proper. Cardiovascular disease is currently responsible for 1/4 of the maternal death in the United States. It is not only in the United States, in all the developing countries, developed countries. In fact, it is not only in developed countries, it is the same trend is we see in Tamil Nadu and Kerala. Be reason for this it is the increasing average age that is well known to us, an increase in known risk factors like diabetes, hypertension, and obesity. It is also in rising, and improvement in medical and surgical management so that the women, child live up to the maternal age to present us with heart disease. That is the main reason. Then, why should you worry about the heart disease and pregnancy? These are all our questions. Because most of this end up with some cardiac problem, mainly the mortality due to congestive cardiac failure or worsening of failure or arrhythmias, thromboembolic phenomena. Thromboembolic phenomena is more in pregnancy because due to hypercoagulable state, much more when it is a cardiac disease added to that. Then rare phenomena like aortic dissection can occur in very rare cases, causing sudden death as in Marfan syndrome. And regarding the fetal side, there will be premature labor. That is very common in heart disease patient, and stillbirth, fewer live births only. That is also common because of hypoxia and other congenital anomalies associated with that. And many of these women will deliver small for dead babies. And of course, these are all the problem for the obstetrician as well as the newborn specialist to take care. And another reason why should we worry about this heart disease is regarding academically or forming a guideline like this, we have very little data regarding the management of heart patients, even in international standard. So there is no a concrete, a fixed guidelines is still be possible to lay out so that it will be easy for everybody to manage. Then the question always arises in our mind, which is the right place for delivery. A woman who has a cardiac problem is pregnant, then she should be delivered in an appropriate place where there are all human resources will be available and equipment should be available. Human resources, I meant a full-time obstetrician, anesthesiologist, physician or cardiologist, and a pediatrician should be available. There should not be any compromise in this structure. So we have plenty of government setups. One side we have the primary health center, then other side, other end of the spectrum, we have government centers for excellence, like Egmore Maternity Hospital, where even the cardiologists are on duty 24/7. So we do have a lot of centers in government setup to manage such patients depending upon the cardiac condition. Coming to the private setup, we have small village hospital run by a single doctor. He invites all the obstetrician and anesthesiologists who travel about 20-30 kilometers to go and operate. At the other end of the spectrum, we have a large corporate hospital who claims to have all the specialists, all the equipments under one roof. So the maternal risk increases as per the severity of the cardiac condition and the comorbid condition. So these patients have every right to be delivered in an appropriate hospital that we have to, as an anesthesiologist, we have to take care of this also. So then the question arises, how to classify the pregnant cardiac patients? This is always a problem, or sometimes it is easy to do that. And number of classifications are available. And one of such classification is the modified World Health Organization, WHO classification regarding the cardiovascular disease in pregnancy. It is one of the easy classification, easy to remember also. In risk 1, that is classified as a 1, the risk is no greater than the general population. That is something like mitral valve prolapse, operated ASD, operated PDA, VSD. In such cases, they behave almost like a normal person. But anyhow, we should have an extra eye on this patient. In risk 2, there will be a small increase in risk in maternal death and complications. Examples will be a repaired tetralogy of Fallot, or a balloon valvolectomy done in a mitral stenotic, still the stenosis is there, and things like that will be a small increase in risk in maternal death. In class 3, 2 and 3 together, put together in via media, there will be a moderate increase in risk factor in maternal mortality as well as morbidity. Such cases will be repaired coarctation of the aorta and tight bicuspid wall, aortic wall, and stenosis. Such cases can be considered as class 2 and 3 put together. In class 3, there is a significant risk of maternal death and complications requiring expert cardiovascular and as well as obstetrical care around the clock, such as spontaneous circulation, untreated cyanotic heart disease, and complex congenital anomaly, a severe pulmonary hypertension. All these cases, we have to think about class 3, which requires around-the-clock service. And class 4, this category of patients, pregnancy is contraindicated due to very high risk of maternal death and complications, like Eschen-Winger syndrome, and ejection fraction is less than 30, and systemic and New York Heart Association says it is class 3 and class 4. In such cases, we have to advise the patient against pregnancy. So this type of classification has to be done by the cardiologist, put together with the cardiologist and anesthesiologist and the obstetrician. There are other classification schedulers also there, CARPEC 2 classification, that is cardiac pregnancy risk scoring. When you look carefully into this risk scoring here, prior event of arrhythmias, New York Heart Association class more than 2, when there is a mechanical valve, when there is ventricular dysfunction, all these things has got around 3 points. When you come to the total scoring system here, When anybody who reaches 3 or 4 points, that means the risk is more than 22 to 41%. Imagine anybody is more than 4 points. If any one of the two symptoms is there, it will reach about 4 points. So when you clinically examine the patient rapidly, it is very easy. When there is a mechanical valve, you can have the risk is more than 15%. When there is a pulmonary hypertension severe, then it is around 2 points. Then both put together, it will be 4 points. So this system, by going by the symptoms and signs, which is easy to classify the patient is also. Coming to modified WHO classification, when you look into this also, when it becomes a class 4, here the risk is around 50%. When class 3, it is around 30%. So this unpalatable truth has to be explained to the patient, probably their relatives, and we have to plan as per the cardiac condition. And similarly in CARPEC 2 also, when you carefully look into the slide, when there is a mechanical valve, the event rate is as much as 38%. When there is a prior event of arrhythmias are there, the problem is up to 33%. Then the New York Association's class more than 3 or 4, it is around 46%. And the odd ratio is also very high. So any one of the classification which suits you has to be done sincerely, and we have to assess the risk stratification of these patients. So pre-delivery evaluation with the anesthesiologist should be done. When I say should be done, so many a time, all of us, we miss this. We deliberately miss, or sometimes we are called in very late. As we enter into the theater, only somebody whispers in our ears, sir, this is pregnancy complicating heart disease. Somebody whispers in your ear. Then you rapidly get into the case sheet and you, to your happiness, the cardiologist would have said, mitral valve collapse. Then you are happy. At the same time, I also have seen right aortic stenosis, bicuspid valve. Then the entire scenario of your mind change. So that type of preoperative assessment should not be done in the current era or scenarios. That is not at all acceptable. So we should make use of this opportunity to identify the patient and triage them to a better hospital. Right. Then what are the things we have to look into that? Again and again, multiple case report says lack of recognition of the heart failure in pregnancy contribute to the major component of the maternal death. Number of articles has come up, number of journals and issues has come in this issue. There is a lack of recognition, or they don't recognize, or they recognize at the last 11th hour. That is the main problem. So as an undergraduate student, as we have been teaching them again and again, taking history is very, very important. Most of this I have seen, more than 50% of the obstetric patients try to hide when there is a cardiac problem. They try to hide us from this. They mislead us. So we have to extract the history right from them. In our place, they will say, it is only சின்ன சர்ஜரி தான் பண்ணாங்க சித்திரத்தினால, அப்புறம் நல்லாயிட்டா, அப்புறம் ஒன்றும் ப்ராப்ளம் இல்லை, ஒன்றும் ப்ராப்ளம் இல்லை. They will keep on telling. They don't want the message to go to the bridegroom house families. So they keep on telling you and try to divert your attention from that. And then you open up the chest and open up the dress and you see a big scar, the vertical scar in the sternum. And you will be worrying what surgery they would have done and things like that. So you have to extract the history vehemently from these patients, and both cardiovascular, obstetric and previous anesthesia history should be extracted. Of course, I need not go in detail about the physical examination. That has to be done by yourself and ascertain the anesthesia work risk in these patients. and all the investigations, and you have to interpret the investigations. Investigations right from the ECG, echocardiogram, sometimes heart pulse monitor, stress test, if it is done well and good. And in certain cases, like pre-pregnancy itself, they will do CT and MRI to ascertain the shunt fraction, ascertain the shunt size, ascertain the valve size, and things like that. So it is mandatory for anesthesiologists to know this, how to interpret, or we can always get the help of our cardiology colleagues. They are now freely available nowadays. Then doing all these things, you have to stratify the risk. And as for the modified WHO or Corpex score, whatever it may be, you have to modify, you have to stratify them and tell the relatives in a clear understanding language what is the risk involved in that. They may have the problem during surgery, or they may have it on the post mortem or post operative time. All these things should be explained politely as well as firmly to the patient, and you have to get the informed consent from this patient. Next step, you have to organize a multidisciplinary team. That is obstetricians, anesthesiologists, and cardiologists and pediatrician, both for vaginal delivery as well as cesarean delivery. And this is very important. So clinical examination, I need not go in detail about history and physical signs and things like that. You are all familiar. But this vital sign, which should not be missed. This you won't miss, but anyhow, I would like to stress. Any patients whose heart rate is more than 120 or systolic blood pressure is more than 160 at rest, any pregnant patient, and systolic pressure or systemic pressure is low, more than less than 90 millimeter of mercury, when the respiratory rate at rest is more than 25 and oxygen saturation 95%, consistently 95% and low, you have to think this patient has got some underlying cardiac problem. No doubt regarding that. That thing you have to take it in mind. And this assessment should also be done periodically. And cardiac physiology and changes in pregnancy, I will not go in detail, but this single figure will bring into your mind all the problems the patient faces. That is, cardiac output right from the 12th week of gestation increases almost to the double, 50% it increases at the time of delivery. Likewise, stroke volume increases, heart rate is also increases. In the other side, when you look into that, hemoglobin is slowly decreases because of the hemodilution. At another point, the systemic vascular resistance is also go down, because you know very well the circulation has to take place in the placenta and things like that. The systemic vascular resistance is also go down. When you consider these 5 factors put together, all these 5 factors are against cardiac vascular system, especially when there is a cardiac disease. That is, increase in cardiac output, increase in blood volume, all these things are against cardiac disease. So these do happen in pregnancy, and that too, if the patient is suffering from cardiac disease, then the patient is pushed into somewhere in a corner. So this is the time where we have to react. This is the place we have to react. As I was preparing the slide, suddenly one thing came into my mind. How ancient days, even nowadays also people believe, looking into the pulse, you can diagnose pregnancy. So I thought, so much of cardiovascular physiology changes that take place, and probably our ancient physicians were able to look into the palpate the pulse and tell the pregnancy, whether it is pregnancy or not pregnancy or things like that. Still our age-old mothers, grandmothers still believe when you visit some other கையை பிடிச்சி பார்த்து இவ மாசமா இருக்கால சொல்லுப்பா அப்படின்னு சொல்றதை இப்பவும் நம்ம கேள்விப்படுறோம். So maybe these physiological changes was detected by our ancient physician. Coming to the subject again, I will enumerate 3 or 4 common cardiac problem we encounter day to day. This problem here in mitral stenosis is a fixed cardiac output. So when there is an elevated blood volume and the heart rate is also increases as in pregnancy, and the increase in left atrial pressure, all these things can lead on to atrial fibrillation and pulmonary edema. Another thing, as I told you, there is a fixed preload and the ventricle cannot cope up with increase in cardiac output. Moreover, in pregnancy, there is a decrease in oncotic pressure, further increases the risk of pulmonary edema in mitral stenosis. Aortic stenosis and hypertrophic obstructive cardiomyopathy, which is furthermore risky one, because a decrease in SVR, that is systemic vascular resistance, that leads on to decrease in diastolic blood pressure, which decreases the coronary perfusion to the thickened left ventricular myocardium. This happens in pregnancy. That too, when we give neuraxial block, the afterload is very much reduced, leading to coronary ischemia. Moreover, when the left ventricular diastolic dysfunction occurs in such cases, the excess volume that is present may lead on to pulmonary edema. Of course, the pregnancy age nowadays, we quite often we see coronary artery disease because of the increase in age, IVF pregnancy and other things, and coronary artery disease is not uncommon. Where here also a decrease in SVR leads to decrease in diastolic blood pressure and decrease in coronary perfusion. Altogether, an increase in heart rate can result in decrease in coronary filling time also. Moreover, the cardiac work is also increased, and during labor, which can leads to hypoxia or the myocardium. Dilated peripartum cardiomyopathy. Whenever the patient gives a history of pericardiomyopathy, surely this patient may go in for risk in the next pregnancy also. So here there is an increase in cardiac output and blood volume. This heart cannot cope up, goes for heart failure and pulmonary edema. And also the oncotic pressure is reduced, so there is pulmonary edema. And many a time, the angiotensin converting enzyme these patients are receiving may be stopped because of the fear of teratogenicity. And this also may be the one of the leading cause for this pulmonary edema and cardiac failure. Pulmonary hypertension, especially the pulmonary hypertension is very severe. 50% of the aortic pressure, or sometimes is more than aortic pressure. It is a dangerous one. Here also the when the cardiac output increases, fixed pulmonary vasculature and right heart failure do occur. Similarly, when there is systemic vascular resistance reduced, the blood flow to the stained right heart is also decreased. Moreover, the pregnancy is a hypercoagulable state, and the pulmonary showers of pulmonary emboli will increase and exacerbate the pulmonary hypertension. Mechanical prosthetic valves. In a hypercoagulable state like pregnancy, there is an increase in valve thrombosis, and vitamin K antagonist may be withdrawn because of the fear of teratogenicity. And suppose if there is suboptimal anticoagulant regime is followed, it may be a determinant factor during pregnancy. Shunt lesion, right to left shunt, a decrease in afterload, that is SVR, increases the right to left shunt, and increases the cyanosis, whereas in left to right shunt, a decrease in SVR decreases the left to right shunt. That doesn't mean a marked increase in SVR will also reduce the preload. So what is our idea? We have to have a plan for a vaginal delivery in heart disease. Vaginal delivery is more superior than the cesarean delivery because the risk of blood loss is less, venous thromboembolic phenomena is less, infection is less. As a dictum, the vaginal delivery, cesarean delivery in this heart patient is only for the obstetric indication, not for the cardiac indication. One or two exceptional cases are there, which I will tell you later. So what is your plan for vaginal delivery? So most of the time, nowadays only, previous eras, vaginal delivery, there is no role for anesthetist. Now, there is a role for anesthetist also, that is increasing. So when you are called in to help in vaginal delivery, you have to apply the standard monitors, no other go. An invasive blood pressure monitor is essential. Invasive blood pressure monitor should not be reserved only for cardiac cases and other major surgical cases. Nowadays, the technique of arterial line, placing the arterial line learned by all the upcoming anesthetists is very easy. And standard, arterial pressure monitoring equipments are also not so costly nowadays. So all these heart patients, whether they come for vaginal delivery or painless labor or cesarean section, we have to have invasive pressure. Then only beat to beat blood pressure can be measured, and there is a shift in fluid shift rapidly occurs. On the top of it, your anesthesia. So unless, as I have told in all the other cardiac situation, the SVR should be maintained. So this is possible only when you have a high standard of monitoring equipments. Of course, CVP monitoring of not much of informative in pregnancy as well as in labor because of the stress and strain. The swing of the CVP will varying too much, so we may not have much information regarding that. Pulmonary artery catheters is reserved only in specified cases like pulmonary hypertension, where you use some pulmonary vasodilators to reduce the pulmonary pressure. In such cases only, this may be useful. Frequent transthoracic echocardiogram is essential, and TEE also may be necessary, and it requires the equipment as also an expert to interpret. Non-invasive cardiac output monitors are also available, but some of the experts believe that validation in pregnancy and labor is not properly done in those non-invasive cardiac output monitor. And all these things, labor anesthesia, some form of labor anesthesia is mandatory for all these patients. You know the reason. That is, a painful labor will provoke and release catecholamines, which will cause the tachycardia, hypertension, hyperventilation, increase in cardiac output unnecessarily. All these things can be blocked by effective labor analgesia. Gold standard of effective labor analgesia is duraxial technique only. That is understood by all of us. And performing neuraxial technique is like epidural, combined epidural is by practice. That is not a very difficult one. The problem here is 2 or 3 things. That is hypotension. How I am going to manage this hypotension, especially in cardiac patients. Of course, we have powerful drugs like phenylephrine, ephedrine, even noradrenaline. Noradrenaline is good in cardiac patients. In some juncture, because it has got a good beta effective also. So unlike phenylephrine is a pure alpha, it has a beta effect also. It is a helps in inotropic and effect. That is one thing that we are worried and how to tackle them. Second is anticoagulant therapy. For some reason, the patient is in anticoagulant therapy, then we have to follow this current guidelines to when to institute it. When the patient is fully on the anticoagulant therapy, it is better not to, it is not, we should not institute neuraxial technique, because the damage and the morbidity of hematoma in the vertebral column is much more dangerous than taking this risk. So we have to assess the risk benefit ratio in favor of not doing neuraxial technique. Other problem in when you do a neuraxial technique, the test dose for epidural medication, this is also gives some worry to us. We generally do the test dose by to ascertain the tip of the catheter, whether it is in the vascular compartment or intrathecally, by injecting around 3 ml of lignocaine with adrenaline 1 in 2000, 2 lakhs thousand adrenaline, so that a few micrograms of adrenaline enter into the venous chamber, produces tachycardia. This tachycardia may be around 20% sometimes, 20% of the normal one, which may be determinant to that particular cardiac patient. So what should we do? We cannot inject air because we are always terrified by the air embolism, that phenomenon. But what can we do? Some authors believe in giving around 50 to 100 micrograms of fentanyl and try to ascertain whether the patient is getting any dizziness, or if she don't complain any dizziness, they believe it is extravascular. So intrathecal, whether the catheter is intrathecal or not, how to ascertain, it is difficult, because lignocaine, when you give around 2 to 3 ml, and this ascend up to sometimes up to thoracic level, then it is dangerous in a cardiac patient. So uncontrolled level it may reach. So some anesthetists, they believe in giving a very dilute dose of Vivivacaine, say 0.125 or 0.0625, 1 or 2 ml can give them and try to ascertain the level. So it is not taken up, then you can think it is epidural, and the catheter is the epidural. It is these are all some ideas, but I would rather say it is some gray areas in cardiac patients. So there is a lot of research can be done in this area to ascertain the epidural catheter in place. Then cesarean, when they decide for cesarean delivery in heart disease, what can is the anesthesia? There are only 2 effective anesthesia possible. That is, one is neuraxial block, as well as another is general anesthesia. So neuraxial block is a good form of anesthesia in most of the 90 to 95% of the cardiac patients, what we see day in, day out. And as I told you, cesarean delivery is reserved only for obstetric indication. And very rarely, as I told you, cardiac indications. That is, when there is a critical valvular stenosis, then we have to think about cesarean section. When severely decompensated heart, where you cannot allow the patient for normal delivery. When there is a pulmonary hypertension, very severe, more than the systemic circulation, there is also during labor, whatever analgesia you give during labor, this may be a problem. So the cardiac associations of European cardiac associations and also American cardiac association, they think these are all the three conditions in which cesarean can be done. In all the other conditions, it is left to the anesthetist and the team to decide whether it is a neuraxial block or general anesthesia. So anesthesia for cesarean delivery, as I told you, neuraxial block can be given in many of the cases, and the neuraxial block, as you are aware, it is spinal. It has got a dense block and rapid fall in BP will occur. Epidural, not a dense block, but a longer time to act and slow fall in BP. Combine spinal and epidural, in which you can get the advantage of dense block as well as slow fall in BP. This can be tried. How we can try means around half a dozen of such cases I also practice, learned from the textbooks. That is, doing a dural puncture, giving around 15 to 25 micrograms of fentanyl, followed by 2 to 3 milligram of hyperbaric bupivacaine. And then the rest of the thing through the epidural catheter, graded doses of small doses of lignocaine 2% with adrenaline. It takes about 15 to 30 minutes for a desired level to set in. By the time you can also adjust the blood pressure and adjust the vasopressors and things like that. Textbooks and journals also says careful titration of spinal catheter anesthesia is also possible in cardiac patients with pregnancy. So do not forget, in all these cases, intraarterial catheter and the blood pressure should be monitored in an invasive manner. When it comes to the cesarean section under general anesthesia, the risk of cardiopulmonary decompensation is always there. And whenever there is a risk of cardiopulmonary decompensation is there, you have to opt for general anesthesia. And when there is a anticoagulant current therapies under the cover of anticoagulant therapy, we have to go for general anesthesia. And severe thrombocytopenia, you have to resort to general anesthesia. And of course, maternal refusal for neuraxial anesthesia, then we have to go for general anesthesia. So general anesthesia is meant only in is mainly meant for cardiovascular decompensation or impending cardiovascular decompensation, because you have to put the patient in the ventilator and things like that. Better you go for general anesthesia from the beginning. Then how to give general anesthesia? This is another thing that is very important. In all the patients, we give muscle relaxant, intubate, and after delivering only we think about giving fentanyl or whatever it may be. But here is a patient, you have to induce, like in any other cardiac patient, you have to give a stiff pre-medication, either fentanyl or other form of narcotics, and other form of narcotics you have to give. And then the patient should be stress-free and intubation stress, and the awareness should not be there. And otherwise, they may go in for tachycardia and hypertension, and these things will lead on to fetal decompensation or fetal depression, which will be taken care by the pediatrician, because the mother's life, of course, fetal life is also important. Mother's life is much more important. So we have to take a full precautions for these patients. Certain drugs that can interfere with our anesthesia, that is commonly used in obstetrics, like oxytocin. Oxytocin reduces systemic vascular resistance, as well as it can reduces the mean arterial pressure. So pulmonary vascular pressure will increase. So this has to be given in an appropriate dose through a infusion pump. Methyl ergometrin, it is a wonderful drug sometimes in pulmonary, PPH, but it produces a sudden increase in pressure, systemic pressure and pulmonary vascular resistance may not be tolerated by cardiac patients. And the prostaglandin F2A, that is a carboblast we generally use, will produce increase in pulmonary arterial pressure and bronchospasm. You have to be careful. Very rarely, obstetrician may use terbutaline as a uterine relaxant. This may also increase the heart rate and myocardial ischemia, contractility, and reduces the SVR in cardiac patient. You have to take care. And another thing regarding the surgical technique, uterus externalization may produce a micro air emboli, which may be dangerous in cardiac patients. But this do occur. This surgical technique, most of the obstetrician nowadays they follow because they can easily suture the corner and things, see the bleeding and all that. But the possibility of air embolism is there when you pull the uterus out. Arrhythmias, atrial fibrillation and paroxysmal supraventricular tachycardia is very common in cardiac patients in pregnancy. Some of the patients may present with pacemaker very rarely, I have not seen, and automated implanted cardiovascular defibrillator. They should be also treated like any other patients only. The drugs will be as usual, like appropriate drug like adenosine, beta adrenergic blocker, calcium channel blocker, and electric. Whenever the arrhythmia lead on to instability of the cardiovascular system, electrical cardioversion has to be given to save the mother, and it will not have any side effect on the fetus. So only one thing I like to stress, the obstetric hospitals and obstetric theater should have a very good stock of all these cardiac drugs and should be replaced periodically. Because out of my experience, I am telling you, many a time these drugs may be missing. It is our duty to look into the rack and see those drugs are available, not run for those drugs at the time of emergency. Then termination of pregnancy. All of a sudden, you will call in for a termination of pregnancy. You may think it is a 5 minutes or 10 minutes procedure, but suddenly you find out this termination is done for a class 4 patients because they want to terminate the pregnancy at their will. So you have to take all precautions like in pregnancy because all complications can occur in this also. So same standard of care in termination to be taken, and you have to choose as per the norms, as per your clinical guidance, neuraxial block or general anesthesia. Medical termination of pregnancy is also accepted in European Society of Cardiology, in which they can judiciously use misoprostol, prostaglandin, or misoprostol, whatever it may be, can be advised in these patients also. To summarize, I would like to stress, pre-delivery anesthetic consultation is mandatory. You should not omit that. Then you have to stratify the risk. And if you happen to work in a small private hospital, we should tell whoever they are in charge to triage the patient to a better center. And you should not hesitate to give your opinion. And you should have a good team for this, as I told you, cardiologist, anesthesiologist, of course, obstetrician and pediatrician, and all the anesthetists whomsoever they are dealing with this, they should have a good knowledge regarding the various cardiac conditions and pregnancy. And labor analgesia should be instituted for all vaginal delivery. This is again a gray area. That is when there is neuraxial labor analgesia is not possible. What is a better choice of analgesia for labor is also questionable because many textbooks says you can give remifentanil and sometimes Internox and things like that. Of course, remifentanil most of us has not seen. So this is again I consider as a gray area. Of course, good knowledge and skill in advanced monitoring we have to develop, and one should not get slackened after delivery. Aggressive postpartum care is also a part of our care for pregnant patients. Thank you.
Thank you, Professor Kannan, sir.
Thank you, sir.
It was a fantastic session. And Dr. Kannan, sir, is icon of ISA Tamil Nadu, and he's the role model for all of us. We are all citizens. Still, we follow your guidelines. First of all, when you take this topic, I thought you are going to touch only the various valvular heart disease. That topic itself is a big topic. Whenever we have one valvular disease, heart disease patient, we have a lot of dilemma. Even now, if I come across any valvular disease patient, I will go through this whole thing and go for what are the anesthetic goals, like that. We refresh. So good knowledge about all the heart diseases must, you rightly pointed out, sir. Thank you very much for covering the vast topic. I have a few questions. Before that, we can open for audience questions. And I need Sudarshan's help also for this. Dr. Sudarshan? Can we have audience questions, or straight away I can go?
Yeah, you please go ahead, sir.
Sir, you said more than 50% of the patient will hide the cardiac. Yes, it is true, sir. Mostly cardiac patients will be referred from here and there, and they will be shifted from various places. Ultimately, they land up in one hospital, and they are mentally fed up and will say, "What is there? I don't have anything. I am all right." Like that, only they will hide. Okay. So good knowledge, thorough history, and we should ask, we should go in depth.
And also, many a time the physician or cardiologist will put an encouraging words. That ஒன்றும் இல்லை, mitral stenosis தான் இருக்குது, அப்புறம் பார்த்துக்கலாம், don't worry. So the don't worry in the word வந்து, it will always, a good word will always strike their mind. So it is, we have to politely tell them what are all the complications. So in that, even if you handle them very politely, many of them will, you would have seen, many of them will become very much agitated by our words. But anyhow, the truth we have to tell them. The risk involved, we have to tell them.
Yeah, there is a way to explain the risk and get the consent.
Yes.
Explaining the risk should be in such a way not to threaten the patient. That is the point you want to.
That's true.
Okay. Sir, for the benefit of the students, I will go for straight away. Among the valvular heart diseases, what are all the heart diseases can be given under regional anesthesia for cesarean delivery?
That is, what are all the heart disease? More than the what are all the heart disease, you have to assess the patient. Assess the patient. Suppose the mitral stenosis, many of the mitral stenosis we do under neuraxial block. But if the mitral stenosis is very tight and there is a fibrillation and there is a history of cardiac failure, then we have to think twice before we enter into regional anesthesia. Then very tight aortic stenosis, very tight aortic stenosis. When you give neuraxial block, there are bound to be a fall in BP, that you have to think twice. Similarly, pulmonary hypertension. You have to be very tight, very severe pulmonary hypertension. We have to think about it twice. And another thing, these are all the things we have to think about it. And cardiomyopathy. When you dilated cardiomyopathy, it is depending upon the patient condition present at the past 1 or 2 days, and you have to assess that. Then only you have to think for neuraxial block or general anesthesia. So it is all, there is no hard and fast rule as such, but individually the patient has to be examined. Suppose a left ventricular failure is there and a JVP is very high, bounding like that, what we see in medical ward, we have to think twice before we opt for neuraxial block.
Sir, we know heart disease patients will be dyspneic and they'll be lean, or they'll be in a failure state, we can easily diagnose. But obstetric cases is totally different because the obstetric case, the normal case itself, if the patient is having anemia or obese or general other obesity. Dr. Muthukumar, sir.
Please mute Dr. Muthukrishnan.
Yeah. In general, the pregnancy cases mimic like heart patients because the physiology and anemia, other comorbid illness, the patient will be dyspneic and edema will be there, and sometimes the ejection systolic murmur, and all the signs and symptoms of failure will be there even if the patient is not having heart disease. So how do we differentiate between the heart disease complicating pregnancy and other diseases? What are the tests you are suggesting, or how to go with that?
So it is a very tough scenario. As you say, it is very difficult only, but to some extent, you can extract history from these patients and also examine the patients for that. The progress of the delivery, progress of the pregnancy, from that you can take some clues from that. So whatever may be, as I told you, certain vital signs I told you. When the heart rate is more than 120, you have to think about this heart patient. There may be a heart problem associated with that. Then the blood pressure is very high or blood pressure is very low. There is no other problem in pregnancy. Then you have to think about this oxygen saturation. When it is low, you have to think about that. All together, all on the top of it, we have now, all the hospitals are now, as in Tamil Nadu, are very well equipped with all the basic investigation tools like echocardiogram and ECG and things like that. And of course, we have manpower like physicians and cardiologists. We have to have whenever we have to doubt, we should not hesitate to consult with our cardiology colleague or physician colleague to pinpoint what disease the patient is suffering. Okay, so it is only a team effort. It is not individually. We cannot always boast like yesterday case. I can diagnose. I can think like that. You have to go by a team, so that you will not miss it. Also, whenever you have a doubt, you take the help of other colleagues of other specialty. That's what I generally do it now.
So previously, or in general, whenever we have cardiac patients with coming for delivery, straight away my seniors and teaching says that go for GA straight away. GA is a golden standard and safe, and nobody can question you if anything happens like that. The scenario is there.
It is still somehow when you say this, the Tamil Nadu government postmortem, they do it on the online postmortem. Some of the people say still believe in cardiac patient means only GA, but it's not like that. So whatever you give a rightly given a epidural block with, you measure the, you may maintain the systemic vascular resistance after load, that is blood pressure, then nothing will happen in a case of mitral stenosis, valve operated and ASD and all these things, nothing happens. But you would have experienced all these things. All of us would have experienced this. So the fear of somebody is catching you is always there. But it is individual patient has to be classified whether they can fit for neuraxial or general anesthesia. It is not a general rule. It's not like that. There are a number of case reports. They are given untreated fellows also under regional anesthesia. And cardiomyopathy is also regional anesthesia, and there is no increase in mortality in both the techniques, general anesthesia and regional anesthesia, in cardiomyopathy also. You can also refer all these things. Right.
So in this case, we cannot strictly say this patient is for fit for a regional, or this case is.
Sorry, sir. Time is running out. We'll let this be the last. And if any question from the chat box also can be quickly asked. Otherwise, we will. One Dr. Rajesh has asked for a question, and because it is getting delayed already 1 hour more.
Please proceed, Sudarshan.
Yeah. We'll, you finish this question, sir. You can complete this question, sir.
Yes. Tell me.
No, we can move on to the audience question, Sudarshan. No problem.
No, because audience. No, you can finish your question. There is only one audience question. You can quickly finish this and.
See,
yeah.
We cannot strictly divide this patient is fit for regional, patient is fit for GA like that.
No,
So,
Perisami, that is not at all possible.
yeah.
And that
So
is
in
not
that
at all
case,
possible.
In that case, if you have taken a case under regional anesthesia and something happens, are we protected legally?
Yes, there is no legal protection. I cannot say whether you are legally protected and things like that. But there is no hard and fast rule so far. This has to be taken under general anesthesia. This has to be taken under regional anesthesia. There is no hard and fast rule. There is no guidelines. Throughout the world, there is no guidelines. That it is you to decide. And it is, if I am your scrutinizing authority, we have to develop a consensus between us. Of course, scrutinizing authority will be always a knowledgeable person, and they will look into all these textbooks and journals. They will not penalize you for taking under regional anesthesia if
there is
certain criteria are fulfilled. Okay.
One question, sir, from Dr. Rajesh is asking: is there any guidelines to predict ideal time for obstetrician to get an anesthesiology opinion regarding pre-anesthetic evaluation electively in pregnant patient? In other words, how early should you see the pre-anesthetic evaluation for an elective cesarean?
There is no guidelines as such laid by any society, but certain practice in certain hospitals is good. Suppose in the hospital where I work, when they come for antenatal checkup itself, if they pick up the patient is a cardiac patient, they will ask me to see the patient. The patient will wait for me, I will check up the patient. And every time they come for obstetric visit, they also visit me. So I also gradually see the patient progress, say the mitral stenosis. Usually the mitral stenosis are unoperated ASDs. Of course, you know very well, nowadays the cardiologist in call in for they do this echocardiogram in the first trimester itself. They pick up a ASD means I follow up the patient throughout. So this is how I think it is a better way. So the patient will have some confidence in you, and you have the confidence in the patient and their family, and you also confident in the progress of the disease, whether you will be able to manage or you will not be able to manage.
Yeah, even if there's any problem, the patient will know the doctor and they will not want to penalize immediately.
Yes.
That is a good rapport you develop.
That is true.
Yes, sir. Thank you, sir. I think with this, I think we will wind this particular first topic. And thank you so much, Kannan sir, for all practical points and tips. And thank you, Chairperson.
If I have taken a lot more time, pardon me for that. Because
no, sir, no problem, sir. It is all useful for all the delegates attending the meeting. Today being a Sunday, 10-15 minutes more, it is not a problem. Everybody will be benefited. And thank you so much. And the second topic, we have a change in the speaker. And Dr. Sunil Pandya, who originally agreed to deliver the topic on pre-eclampsia, could not join us due to unavoidable health reasons. Instead, I really thank to take up the mantle at the last minute, Dr. Mangal Swati from Obstetric Institute, Chennai, who was readily accepted to present the same topic, which they prepared it well. And then I'm requesting the chairperson, Dr. Periswamy, to introduce the speaker, Dr. Mangal Swati, and then progress to the second lecture for the day. Thank you. Over to Dr. Periswamy.
Thank you, Dr. Sudhir. let me take 2 minutes to thank the ISA. Really, it is a fantastic session. Second monthly ISA Tamil Nadu webinar. Thanks for the opportunity given to moderate this session. Respected President ISA Tamil Nadu, Secretary, and all the past presidents, GC members, and my colleagues, and the person, Dr. Veerasan, who accompanied me for moderating this session. Thank you all. This is, as Dr. Sudarshan said, it is a last minute arrangement. Dr. Mangal Swati volunteered to present the same topic at the last minute. It is a really great thing. Dr. Mangal Madi is having degree MBBS, MD, and DNB anesthesiology. She is an assistant professor anesthesiology in the Institute of Social Obstetrics and Government Kasturba Gandhi Medical College, Hospital and Children. She did her MBBS, PhD, Institute of Medical Sciences, MD, Government Kilpak Medical College and Government Rayapeta Hospital, Chennai. She had 2 publications, and the second one I wanted to highlight, anesthetic management of a COVID positive parturient with a newly diagnosed cardiomyopathy presenting with the supraventricular tachycardia in Journal of Clinical Anesthesia. She's having a vast experience in the field of obstetric anesthesia. So that she volunteered immediately. Now it is a time. Over to you, Mangal Swati, to present unique path in the approach of preeclampsia. What is new from the past?
Good morning to one and all present here. Am I audible, sir?
Doctor, I guess you have joined with the 2 systems. Can you just...
You have to mute one system.
Or maybe someone is next to you who has joined the same meeting.
Madam, am I audible now?
Yes, ma'am. Perfect.
Yeah. So the topic given to me is on preeclampsia management from anesthetic perspective. What is new from the past? So first of all, before going on with my presentation, I would like to thank all the ISA board members, Honorable President, Vice President, Treasurer, and the organizing secretary for giving me this golden opportunity to be a part of this online CME and to present this topic to you. So let me share my presentation now. Is my presentation visible, sir?
No,
Not at all.
not.
No, madam.
Now we can see a white screen.
Yeah, now is it visible, madam?
No.
Sorry.
Is it only? It's only white screen.
Excuse me, sir, I've joined through another system. Can you please help me share the presentation?
Name, ma'am. The other system ka name in which you have joined.
Dr. Swati. Name in the other system.
Yes, ma'am. Please, now you try to share the screen.
Yeah. Sorry, I'm having a problem. I guess I'm not able to connect to the presentation. I'm checking on it. Sorry for the delay. I have the PPT, sorry, but I'm not able to share it.
So, can you share the PPT to Shilpa?
Is it now visible? Is it now visible?
Ma'am, you have to share the screen.
Share the screen. 1 second. I'm sharing the screen, but
Can you share the PPT to Shilpa? Shilpa, can you project from your side?
Okay.
okay. Sir, can I share the PPT to you, sir?
You're going to share to me.
Yes,
Yeah,
sir.
please send, yeah, send by WhatsApp.
Yeah. Yes, sir, I've sent it to you. Sorry for the delay.
Shilpa, I have shared the PPT to you. Can you share it from your screen?
Okay, give me 1 minute.
Shilpa, did you get it? Hello?
Yeah, sir, I'm downloading.
Thank you, ma'am. Thank you, sir. Sorry for the delay.
Let me share in the time gap about the preeclampsia and complications. Can I share one experience? Yeah, now it is opened.
Sir, you can.
Sometimes technology puts you down. It doesn't matter. Excuse, kindly apologies for the delay.
You can share your experience, sir,
Yeah.
please.
Sir,
Speaker
now
ready?
the screen is open, sir.
I think speaker is ready.
Sir, it's
Yeah.
okay, sir. You can share your thing,
It's
sir.
not your
No, no.
presentation.
Yeah, it's the presentation.
Okay. Okay, sir. So my
You
topic
go full
is
screen. You
Yeah.
go full screen, doctor.
Shilpa? Shilpa, can you make it as full screen? Okay.
The lower down.
Now Shilpa is projecting from her screen, I can play.
Yeah, Shilpa can do.
Yeah.
So
Yes, sir.
my topic is on the recent advances in the approach to preeclampsia from the anesthesia perspective. Go on to the next slide, please.
Shilpa.
So coming to the epidemiology, we all know that preeclampsia has been a major cause for maternal mortality and morbidity. So the prevalence has been estimated to be 7 to 8%. In India, the incidence has been reported to be a bit high, between 8 to 10%, according to the recent research article. Next slide, please. Yeah, the classification of hypertensive disorders, as we all know, it is chronic hypertension, gestational hypertension, preeclampsia and eclampsia superimposed, and chronic hypertension superimposed on preeclampsia. Next slide, please. Yeah, we all know that the definition is of the gestational hypertension is new onset hypertension, which is presenting after 20 weeks of gestation with significant proteinuria. So actually, this was the older definition wherein you have new onset hypertension and proteinuria as a criteria with a spot urine creatinine ratio more than 30 mg per millimole or 24-hour urine excretion, protein excretion is estimated to be more than equal to 300. So we have the classification of gestational hypertension and preeclampsia as mild, moderate, and severe, with the 140 to 149 bar 90 to 99 as the mild, moderate varying from 150 to 159 bar 100 to 109, and severe preeclampsia with more than or equal to 160, 110 with the presence of system involvement, multi-organ involvement. Next slide, please. So now the definition has been revised as it is a new onset hypertension developing after 20 weeks of pregnancy with one or more of the following criteria. So either proteinuria, even organ dysfunction is included in the definition of preeclampsia, either be it hepatic, hematological, or neurological complications, along with IUGR. So new onset hypertension with any one of the following criteria goes by the definition of gestational hypertension. Next slide, please. So coming to etiopathogenesis, as we all know, there are maternal and the placental factor involved. So the main factor being the failure of the trophoblasts to invade the uterine spiral arteries, so which results in impairment of the vascular remodeling. So what we need to know is that preeclampsia is basically something to do with vasculature. So that a vascular remodeling is impaired, because of which there is endothelial dysfunction. This is the early onset preeclampsia. The placental factor of preeclampsia has been told as the etiology for the early onset preeclampsia. So there is one more entity called as late onset preeclampsia, wherein there is maternal predisposition to the hypertensive disorder. So there is basically an imbalance between the pro-angiogenic factors and the anti-angiogenic factors. Because of this, there is endothelial dysfunction and there are leaky capillaries. So the vasculature, the entire remodeling of the vasculature is impaired. So there is inflammation happening everywhere in the vasculature. So what you have to remember is that preeclampsia is a multi-system involvement with multi-organ dysfunction due to impairment of the vascular remodeling, and it is characterized by inflammation everywhere in the organ systems. So this is the take-home message. So the placenta becomes hypoxemic and ischemic because of the occlusive spasm of the arterioles. So there is fetal growth retardation as a result of preeclampsia affecting the fetus. Next slide, please. Yes, clinical spectra, as we all know, as I already told you in the etiopathogenesis, it is going to affect all the organ systems. So starting from the head to toe, you can remember. So in the central nervous system, there is raised ICT, and the mother is prone for intracranial hemorrhage. So raised ICT signs, as we all know, we assess clinically by symptoms of headache, blurring of vision or visual disturbances, and the florid raise in ICT can make the mother prone for convulsions. So coming to the cardiovascular system, because of the unopposed hypertensive disorder, there might be a strain on the myocardium and the left ventricle with left ventricular diastolic dysfunction. So it also affects the liver. We all know that it can affect even the liver and the kidneys. Coagulation, we all know it's an important part happening in the liver. So there is coagulopathy leading on to your thrombocytopenia, disseminated intravascular coagulation, and hence the HELP syndrome. So coming to the respiratory system, we all know that it is a leaky capillary syndrome. So it is a vasoconstricted state, but then where is the fluid overload? The fluid overload is fully in the interstitial space. So the vasculature is contracted, but the third space has become overloaded, which predisposes to pulmonary edema. And we all know by the physiological changes of pregnancy that we have upper airway edema in the pregnancy, and this gets accentuated because of the preeclampsia. In the liver, you have all the raised liver enzymes, coagulopathy, and hepatic rupture. It does occur, though it's a rare complication. And in renal system, there is renal vasoconstriction. So the renal blood flow is affected, because of which the urine output is reduced and the protein gets excreted. So in the coming to the fetus, the concerns are IUGR, preterm labor, and uncorrected the hypertensive disorders can also go in for abruption. Next slide, please. Yeah, the laboratory parameters to be checked on is, as we all know, we go on with the basic investigations first, the complete blood count. We get a basic hemoglobin, platelet count, the blood counts. So platelet is one of the important factors. So in HELP syndrome, as we all know, there's thrombocytopenia. So getting a HB and platelet done is a very basic investigation. Then you go on with the renal functions and the liver functions. So because it's a multi-system involvement, even the urea, creatinine, and LDH, which is a marker for hemolysis, and LFTs play an important role if there is a organ affliction. As usual, you see the urine proteinuria and your urine spot PCR. And of course, the coagulation profile, if you do have time in getting all these investigations done. The first thing is the CBC, the basic investigations, the renal, liver, and followed by your coagulation profile. Next slide, please. Yeah, there are some of the novel predictors which have been found out to assess the onset of gestational hypertension and prediction for preeclampsia. These are the novel predictors which have come in the recent updates: serum glycosylated fibronectin, tyrosine kinase, platelet growth factors, and placental protein A. And uterine artery Doppler also plays a significant role in finding out the preeclamptic, in presence of preeclampsia in the early weeks of gestation. Next slide, please. Yes, so we have seen the classification of hypertensive disorders, the definition, the clinical spectra, the lab parameters. So the important thing we are coming now is to the anesthetic management. From our perspective, what we are doing now different? What is the difference from the past? So we all know the role of the anesthetist, whether for a cesarean section or for a labor natural. we do stand an important role. So the important thing is that well-controlled hypertensive patient for a vaginal delivery poses no risk. Only when there is a need or an indication, we institute labor analgesia. Otherwise, we don't intervene. And when such patients are taken up for C-section, mild to moderate preeclampsia with well-controlled BP and no organ affliction, we can go in for regional. In case there is any superimposed eclampsia, first we need to manage the control the seizures first. And we address to the management of the convulsions plus the fluid management. And based on the patient parameters, we decide whether to institute a regional or a general anesthesia. Next slide, please. So our concerns are, preoperative concerns are, we need to bring the BP under control. So we need to have the fluid management in mind as well, as there is generalized vasoconstriction. The vasculature is fully contracted and volume depleted. In case of the organ systems are affected, there are chances for oliguria. In case we are going to institute general anesthesia, we must account in mind of the hypertensive stress response. And convulsions can happen either antepartum, intrapartum, or postpartum. Even in postoperative period, even though the pregnancy is terminated, for the first 48 to 72 hours, we have seen patients, they do pose a risk for getting convulsions even in the postoperative period, even after C-section. Of course, the airway edema, and of course, in severe preeclampsia, you have periorbital edema, the puffiness of the face, the swelling of hands and feet, the difficult IV access, and the difficult regional technique. So these are the preoperative things which we need to keep in mind before anesthetizing a patient. Next slide, please. Yeah, so as I already told you, the preoperative optimization involves controlling the blood pressure. We have oral and IV antihypertensive agents, and I'll just touch upon a few. The gold standard one which we use is the labetalol. So for a severe hypertension, for uncontrolled hypertension, we give IV labetalol starting with a dose of 20 mg, and we go up till, we can go in increments of 20, 40, 80, up to 220 mg IV can be given. But practically, we don't wait until that. In either case, we go on with labetalol and Maxil and straight away start an infusion if the BP still appears to be uncontrolled, even after 80 mg IV of labetalol. And Maxil, of course, for neuroprotection, definitely in order to, you all know that it's a calcium channel antagonist, it's a vasodilator, so it is going to bring about a decrease in the ICT, and it's also a vasodilator. So the Maxil dose, for the interest of the postgraduates, you all know that it is 4 to 6 grams IV loading dose, which is given very slow in 20 minutes, followed by 1 to 2 grams per hour infusion. 2 to 4 grams per hour can be given in case of recurrence of seizures. And of course, you need to monitor the magnesium levels. The magnesium levels are important. And this Maxil infusion, what they do is usually they start 24 hours prior to the, when they label a patient as a severe preeclampsia, with immediate control of blood pressure is needed. So they start the Maxil infusion 24 hours prior to the termination of pregnancy, and then they continue 24 to 48 hours post-delivery also, be it a cesarean section or a labor natural. So this is the one which is followed in our obstetrics center. So as you all know, the seizure control, any eclampsia patient, you have to give anti-epileptics. You have to secure the airway first. Airway management is the main thing involved in the protecting the airway, and then the termination of the seizures by our anti-epileptics. You can in the theater we have all our induction agents are basically going to be bring down all your ICT, and they will work as wonders and as anti-epileptics. But from the obstetric perspective view, they Levipil does have a role. They start Levipil in a stabilized patient in case you're encountering any seizures in the intraoperative period on table. You have all your propofol and thiopentone, which is going to bring down all your raised ICT and work as excellent antiepileptics. And of course, the management of pulmonary edema being positive pressure ventilation, and you drive the excess fluid out of the third space, out of the interstitial space. And your morphine is a gold standard drug in management of pulmonary edema, along with diuretics, furosemide. But morphine can be instituted in a ventilated patient, whereas furosemide or Lasix can be given as a first choice in a patient who's still conscious and needs some support, needs some supplemental oxygen, but not entirely ventilated. Next slide, please. Yeah, now coming to the proper anesthetic management, we have two options, whether to institute a regional anesthesia, that is spinal, or a general anesthesia. So epidural anesthesia, coming to that, we usually tend to avoid in case of severe preeclampsia or in cases where there is coagulopathy. So we don't want an hematoma or a paraplegia or paraparesis. So in order to be cautious about it, I would say that epidural has got a little role in the management of preeclampsia unless there is any other specific indications. So spinal is the gold standard. Coming to neuraxial anesthesia, but for which patients do you go for spinal? So let's weigh the pros and cons. So in a well-controlled patient with no multi-system organ involvement, and the CNS involvement is ruled out with no imminent signs of eclampsia, we can safely go ahead and institute a spinal anesthesia. Also coming to the advantages of the spinal anesthesia, as we all know, we are bothered about the airway. The airway is getting safe. There's no intubation, stress response, or failed intubation. There is no polypharmacy happening here with a lot of drugs, and it's safer and quick to institute. So at the same time, in a well-controlled hypertension, it is safe to institute, and the risk of hypertension will be minimal. So provided we have controlled the blood pressure to some extent. Next slide, please. Yeah, coming to the general anesthesia, the risk and the need. So for which patients we go on with general anesthesia? So for those patients who have thrown convulsions or who have thrown convulsions but still have not recovered from the post-ictal state, or whose mental status is still obtended and who are hypoxic and with presence of multi-organ involvement, wherein the risk of hypotension does precipitate any organ dysfunction and coagulopathy, or with thrombocytopenia with a platelet count of less than 75,000. So for those patients, we go in for general anesthesia. So we have controlled, the pros being we have the airway which is controlled, and of course we have managed the seizures and we have intubated. So even when there is any pulmonary edema, the positive pressure ventilation is the management for it. So early intubation goes without a problem, as already said. So regional, you always carry a risk of hematoma. More than spinal, epidural does carry a significant risk of hematoma. So what are the risks involved? The cons being the stress response. Of course, you need to have all your agents for stress response. You need to have all your vasodilators and drugs for reducing the blood pressure, like you have labetalol, NTG. So you can have those drugs for attenuating the stress response. And there is risk of difficult intubation because the upper airway is edematous. So, and you also have some fetal depression due to the polypharmacy of the drugs. Next slide, please. So as I already pointed out and highlighted, the indications for general anesthesia is the imminent eclampsia or in a patient who has convulsed but not regained the consciousness with presence of raised ICT. They pose increased risk for general anesthesia. So, and in the presence of coagulation abnormalities. So, and the indications is patient refusal for regional or any anatomical abnormalities or any sepsis at the site of regional block. These are the indications for general anesthesia. So next slide, please. Yeah. So how do you prepare for general anesthesia? So your airway assessment and preparedness is more than anything to do with general anesthesia. And annulling the stress response, as already told, since there's polypharmacy of drugs, your choice of relaxants have to be very cautiously titrated, because if there is the presence of organ dysfunction, if there is renal and liver and hepatic involvement, so with deranged enzymes and with deranged renal functions, you do have to go on with cautious using of your volatiles and relaxants. And similarly, even your NSAIDs with deranged liver enzymes and opioids, you just have to go down by the dose. You just have to use it cautiously as you're using the polypharmacy choice of drugs. And also extubation part has to be very smooth, not to create any stress response. So your labetalol and NTG will work very good for extubation response, in handling extubation response. Yeah. Next slide, please. Yeah, the postpartum care, as already pointed out, it has to be in a well-monitored recovery room, be it an ICU care or a step-down ICU care. It has to be managed by a multidisciplinary team. And the antihypertensive, most of the times, antihypertensive therapy needs to be continued post-operatively. So even if the parturian delivers, even by labor natural or by C-section, the physiological changes, as we all know, take time to regress. So the antihypertensive therapy mostly needs to be titrated and continued even in the post-delivery period. And as I already pointed out about the anticonvulsant therapy, Maxil, we are continuing 48 hours, totally 24 hours prior to delivery and 48 hours post-delivery we are instituting. And of course, careful monitoring of all our vital parameters, because even in the postpartum period, there is risk of the patient getting convulsions and going in for pulmonary edema. So you need to carefully monitor. So bring down the blood pressure under strict control, the target being less than or equal to at least 140/90, so that the autoregulation is not impaired. Yes, next slide. Yeah, this just I want to highlight a case which we managed recently. It's a case of 28-year-old in our obstetric institute. So it's a case of 28-year-old primary near term on treatment for preeclampsia. At the PHC referred to us with convulsions. So she was referred to us with convulsions. We managed the convulsions. We gave supplemental oxygen. We gave antiepileptics, Levipil, and she was not hypoxic. She was managing very well with an oxygen mask. And half an hour or so, she regained her consciousness. And 4 hours after which she was completely conscious and oriented. The raised ICT was ruled out by clinical assessment, and she was planned for termination because it's severe preeclampsia. Termination was planned after a period of 4 hours. C-section was planned, and the organ systems coming to by then we could get all the blood investigations done. Coagulation profile was normal and the organ systems were normal. So the patient was taken up under spinal anesthesia, almost with nil complication, and managed in the intensive care and rigorously monitored post-operatively with nil complication. Yeah. So these are some of the risk predictor models. So many risk predictor models are coming to vogue now for early onset preeclampsia, which the obstetricians might be much aware of. You all know the risk factors being elderly, primary, obesity, and coexisting maternal gestational diabetes. All these are risk factors for preeclampsia. So there are some these are some risk predictor scores, basically to detect it earlier. Yeah. So coming to the conclusion, so the many a times, the patients are referred to us. Being a tertiary care institute, it's patients are getting referred from the PHCs for control of blood pressure or control of seizures, or an eclamptic women may get referred, or severe preeclampsia might get referred, or with one recording of just uncontrolled BP, and we settle down the blood pressure. We have time for all the investigations, and then we plan the patient for either a induction or a C-section based on the blood pressure control. So early detection and early institution of care so helps in preventing morbidity. Preeclampsia is a vast topic, so I'm able to cover a gist of it. So from our perspective, we have to be prepared for instituting either regional or general anesthesia, well prepared with all our hypertensive agents, both oral nifedipine also has a role. I forgot to tell about it. Sublingual nifedipine has a good role. You can give 10 mg and you can repeat every 20 minutes up to a maximum dose of 50 mg. It does have a role because many hypertensives, AZ inhibitors, you won't be able to use because it's contraindicated in pregnancy. Though they do institute all these antihypertensives in the post-natal period or a post-operative period. So the labetalol is the golden drug of choice, followed by nifedipine. So our preparedness in managing the uncontrolled hypertension, control of seizures, airway management, taking a look at the organ involvement and deciding on the right choice of anesthesia, and our role continues into the post-operative management in the ICU care. So all these help to prevent the preeclampsia related complications. Yeah, thank you. Yeah, thank you.
Thank you, Dr. for your very lucid presentation of the topic. Over to chairpersons, Dr. Periswamy and Dr. Veerasham, please.
That was a very nice presentation, Dr. Swati.
Thank you, sir. Thank you very much.
You asked in the last minute, you have covered everything in detail.
Thank you, sir. I was able to cover a gist of it. Though I was in a hurry in preparing for this presentation, could not have much time in elaborating on many things and including many things in the PowerPoint. So, thanks for giving me this opportunity to present a gist of it.
Yeah.
And all your
Dr. Veerasham, unmute you, please, sir. Dr. Veerasham is talking. Please unmute yourself and talk, sir. Chairperson, sir.
Yeah. It's very good.
Now.
Both of them are very good speakers, and one is the senior, and the other one is the young anesthesiologist with a lot of experience in obstetric anesthesia. Especially, she dealt the preeclampsia. Probably she's having good experience in obstetric hospital, and most of the Thank you, and very good organized webinar on behalf of our Kasturi and President, Secretary and Treasurer of ISA Tamil Nadu. Nice presentation. Nice academic feast.
Thank you.
Right.
Doctor, there is a question.
Yes, sir.
Labetalol versus nitroglycerin. Which is more safe in attenuating stress response? This is from Dr. Sundaram.
Okay, sir. So our first choice is labetalol, sir. So because we all know that NTG, both are short-acting drugs, but NTG, it is better when you institute it as an infusion rather than it as a bolus, but labetalol, we have doses going up from 20 mg IV up to 220 mg IV. I would say that if your blood pressure is not getting controlled or needs an add-on hypertensive, then we could institute an NTG. This is what is my thoughts.
What about
Seniors
the esmolol? Is there any role? What
Yes,
about
sir?
the esmolol
Yes, sir.
in general
Esmolol,
anesthesia?
yes, sir. Being a beta selective blocker, it does have a role in attenuating stress response. So we are more bothered about tachycardia as well as hypertension. So esmolol does bring down the heart rate excellently, also the blood pressure, but it being a beta selective blocker, we can use esmolol both during intubation as well as during extubation. We have used it, sir. It has been found to be very useful in controlling heart rate.
Thank you.
There is another question.
Yes,
One of the delegate has posted. Even I wanted to initiate the talk on nifedipine, but that person has asked for can nifedipine given in antepartum as by itself is a relaxant and may cause PPH. So do you recommend nifedipine?
Not so, sir, but nifedipine is not the first choice. In our institute, what they do is tablet labetalol is the first choice, provided the patient does not land up in a hypertensive emergency. For controlling the blood pressure, we go on with oral labetalol first. Only in severe preeclampsia, provided we are not taking up or we are not planning for the termination at the moment, we also add sublingual oral nifedipine. Or if the patient is going to be planned in a 24-hour or 248 hours, nifedipine will be held as a reserve antihypertensive for severe cases.
One comment on nifedipine, Dr. Perisami, I will just conclude one question.
I'm in a regular obstetric practice.
Yes, yes, sir. Please, sir. I would like to hear more from the seniors and I would like to learn from this presentation.
Dr. Perisami, sir.
Yeah, it is a PA like the terminology name change, hypertension, induced hypertension, disorders of pregnancy, all the diseases in the same way, hypertension also changed a lot. We used to give alpha methyl-dopamine. Now it completely changed. First choice. Nifedipine not sublingual. Oral is the choice. Sublingual, oral. Sublingual is.
I had a comment to make on that only, sir. Nifedipine never to be given sublingual because the absorption itself is happening only in the stomach. Even if you give nifedipine in the sublingual area, what will happen is there is a dangerous proposition here. You puncture the nifedipine. When we used to do postgraduate about 25 years ago, that was the culture. But then the nifedipine never gets absorbed in the mouth. It is always in the stomach. If you squeeze the nifedipine, the erratic dose of that slowly transits down into the esophagus and goes to the stomach. So at a variable time interval, the absorption of the drug takes place. And then what happens is it is very erratic in its performance. So suddenly a large dose might go down or unpredictable dose. So the predictable BP control is not very good. So as Dr. Perisami rightly pointed out, never to be given the sublingual nifedipine. It is either orally or you can give a Ryle's tube. If you have a Ryle's tube inserted, push it through the Ryle's tube, dilute and give it through the Ryle's tube. But never, it is absorption of nifedipine almost always takes place only in the stomach. So please change the concept of giving sublingual nifedipine at any scenario, for any patient for that matter. You have much better drugs to be given.
Okay. So this has been a great learning point. So thank you, sir.
No. What is the role of epidural anesthesia in your institute? You are not practicing epidural anesthesia in preeclamptic patients?
Only when there is for a role in preeclampsia, the epidural, we don't institute it regularly unless it is indicated, or for any labor analgesia on a preeclamptic women with well-controlled blood pressure, in whom we need to institute labor epidural, we go ahead, sir. So otherwise, most of the cases, we go ahead with a single shot spinal for C-section.
Okay.
Do you use any additives, madam?
Yes, sir. Yes, sir. Fentanyl and buprenorphine we use. They have worked to be wonderful in not causing so much hypotension, and the levels are the blockade is very well regulated, not enough to cause hypotension. So we can go down with the dose of bupivacaine with some additives, buprenorphine 30 mics or fentanyl maybe 20 to 25 mics.
What's your experience on the currently in thing segmental spinal? People keep telling about it. Do you advocate that? Recommend it in any way?
Not regularly practice, sir. I need to hear some knowledge about it. I need to have not really practiced. So need to have some inputs and learn.
I have no experience as well. Anybody is having experience can please share.
Yeah, please share. I would like to.
Nowadays, segmental spinal.
Yeah, I would like to hear from the seniors.
I don't think anyone is got the. I've seen few papers from Kanpur Medical College during COVID time. COVID positive patient pre-eclampsia, segmental spinal was given, and then patient was safely managed. They said that was one and two studies. One of the senior professors I had seen that, but I had not heard anybody who is routinely doing it. Any input, sir, from anyone?
From my side, no.
No. We don't have. We don't practice segmental spinal.
Segmental spinal. Kannan, sir.
Okay.
Segmental spinal. Unmute, sir.
Yeah, never practice segmental spinal injury.
Yeah.
I never practice.
So pre-eclampsia, inbuilding eclampsia. One thing, never forget the role of coagulation profile.
Yes,
because
sir.
many a time, that is one very important thing you have mentioned. And take home, people should remember whatever little time they have, they should ideally do the coagulation profile.
Yes,
So
sir.
over to chairpersons, any other comments?
Role of MAC-self in pre-eclampsia, early pre-eclampsia.
I think she touched on that.
If there is if the patient's blood pressure is well controlled, if she is going to fall in the category of mild preeclampsia, we don't routinely institute MAC-self. But for moderate to severe cases wherein the blood pressure is more than 150/90, we do institute MAC-self as a prophylactic anticonvulsant therapy. So it does have a role in moderate to severe cases, wherein, as I've told, we institute 24 hours prior to delivery and continue it in the post-delivery period up to 48 hours.
Ma'am, novel predictors. Is there anybody or any center is doing all those things, glycosylated fibronectin, tyrosine kinase, like that?
Actually, it has been included from the articles and journals, sir. I'm yet to get knowledge about the current practice of these predictors in our use. So this I have taken not only from the anesthesia journals, from also from the certain obstetric journals. I'm yet to get knowledge about us practicing these, whether we are going ahead or any predictor is available. I'm yet to get knowledge about it.
So, but there have been studies going for this 12th week ultrasound, so uterine artery thing that has been going on. There will be some postgraduate dissertation topics have been started. Probably in next coming years, we may get a clear-cut idea on this thing, sir.
Yeah, there is some questions which we need to say. You want to answer, doctor? Or?
Yeah, yes, of course. So we can discuss. Yeah.
Yeah, a few questions. One is hydralazine tablet. Dr. Ganesan is asking for it as a third drug, other than the drugs which you mentioned. What's your experience on hydralazine?
Yes, sir. Hydralazine we've not used much, sir, but it is held as a third choice third choice of
Yeah, that's exactly
antihypertensive.
what.
Only as per my experience, for one patient, I remember I have used 10 to 20 mg, in whom the control didn't come at all with my routine labetalol and the NTG infusion. So I had to go on with an excellent vasodilator, which is hydralazine. I've just used it once, practically.
Yeah, but the trick is when you start hydralazine, you have to make the decision whether you want to continue the pregnancy or then immediately quickly go ahead and terminate. So
Yes,
I think that is, yeah,
yes, sir.
I think the more in terms of going in for a early cesarean will
Termination.
be
Yes, sir. Yes,
termination will be the option, I think.
yes, sir.
No other choice. And what is the role of furosemide in preeclampsia in your current practice?
Role of yes, a role of furosemide, wherein we have a moderate to severe preeclamptic patient, wherein the urine output is, there is we all know that there's excessive renal vasoconstriction, and in whom there is a mild decrease in the urine output, or in whom you expect that your both your pulmonary edema and your renal complications shouldn't happen. So in those cases of severe preeclampsia, Lasix does have a role, sir. We do prophylactic.
Yeah, it is a very tricky drug to use. Actually,
yes,
it is not something which is the first line thought process to come in.
Yes, sir.
So I think with that, any other questions? We have almost crossed 1 o'clock. President is looking at me to close the session early. So I think it will be time for us, and I thank the chairpersons, both the senior Professor Periyaswamy and Professor Veerasham from Telangana, for having joined, and the two excellent speakers, Professor Kannan sir and Dr. Swati, for having taken up the responsibility at the last day. And you did a wonderful job and explaining all the facts and the details. Kannan sir, thank you so much for sharing your immense knowledge, wealth of experience.
Thank you.
And then with this, we close the academic session and over to President to conclude along with the Secretary. Thank you.
Thank you, sir. Thank you, sir. Thank you for giving me this golden opportunity. Thank you, respected professors and all emeritus teachers.
This is Dr. Bhaskar. Can I, Sir Kumar sir, can I talk?
Yeah, please proceed, Bhaskar.
Sir, can I call Dr. Muthraj, the Secretary of Tirunelveli branch? Can he present his his city branch report, sir? Dr. Muthraj?
Yes, sir.
Sir, you can present your city report, sir.
Yeah, sir. Good afternoon, sir, everyone. And in our city branch, as we all know, for the past couple of years, due to COVID, we could not do any physical activities. But at the end of this last year, we did a meeting, physical meeting. By the time the Professor Amazarani was elevated as a state vice president, she stepped down from the president post in our local Tirunelveli district branch. So that time we conducted a small CME on the topic regarding the cardiac patient for anesthesia. Dr. Sellokumar from Velamal Hospital had come to our branch in our ISA house, and he did a wonderful conversation about managing the cardiac patients. And that was about 45 delegates attended, including the postgraduates from Tirunelveli Medical College. And it was wonderful. And beyond that point, we could not have much more academic activities. But by the time it was well backed up by our state ISA branch by continuous academic activities like this. And we are happy to have this. And that's all, sir.
Thank you.
Thank you, sir. Sir Kumar sir, you can take over, sir.
Yeah, please. No problem. Proceed with the vote of thanks. Already we are.
Yes, sir. We are almost at the end of this. Sir. Now I call upon Dr. Giridharan, our treasurer, to present with the vote of thanks, sir.
Good afternoon, one and all. I would like to present the thanks on behalf of our team, the academic chairperson, Tamil Nadu ISA, Dr. Sudarshan, President, Tamil Nadu ISA, Dr. Kumar sir, Vice President ISA Tamil Nadu Dr. Amdarani, Secretary ISA Tamil Nadu Dr. Bhaskar. First of all, I would like to thank the God Almighty for making this CME in a grand way in spite of few hiccups in this program. First of all, a drop in the speaker and then few technical issues. I thank the God Almighty for making this a good session. I thank the chairperson, Dr. V. Resham, ISA Telangana, and Dr. Perisami, ISA Trichy, for moderating the session and giving their inputs about the obstetric anesthesia. And I thank the speaker, Professor Kannan sir, ISA Tirunelveli, for his sharing his experience regarding cardiac problems in obstetrics, and Dr. Pankaj Swati for an excellent presentation in a short span of ISA Chennai on preeclampsia. I also thank the past president, past secretary, and senior office bearers and Tamil Nadu ISA colleagues and postgraduates for attending this program. I thank the Neon for sponsoring this AV Visual CME program. I thank even Logistics for their audio-visual activities. I once again thank the God Almighty for making this a grand success. Long live. Thank you.
Thank you so much.
Thank you, sir. Thank you, sir. Thank you, sir. We close the session.
Good to see Dr. Renu after a long time. Hello, madam.
It was a very good session. Thank you.
Thank you, madam. Thank you so much, madam.
Thank you, sir. Thank you.
என்னோட எக்ஸ்பீரியன்ஸ் சொல்ல நினைச்சேன், கடைசி வரைக்கும் வாய்ப்பே கொடுக்கல நீங்க.
உங்களுக்கு இருக்கிற
சொல்லுங்க சார், என்ன சார்
ஃபுல்லா சொல்லலாம் சார். இன்னைக்கு ஃபுல்லா சொல்லலாம் சார். உங்க எக்ஸ்பீரியன்ஸ் சொல்ல ஆரம்பிச்சீங்கன்னா. Very thank you, sir. Thank you very much.
Thank you, sir. We'll meet next week, next month, sir. No problem. Thank you, sir. Thank you. Thank you. Have a good day.
Thank you,
sir. Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you. Bye bye.
Thank you.
Thank you. You can close the meeting. Thank you very much.
Thank you, sir. Thank you all. Thank you.
Thank you. Thank you all.